Why is it so important? Is quite simply, it saves lives. And we'll talk a little bit about that. You can see the effects of immobility on our patients. The exercise helps to improve muscle tone, and lack of muscle, using our muscles, leads to atrophy, which is the wasting away of muscle. And I think these pictures illustrate that. On the left, you can see a person who had been in a full leg cast, and they took the cast off, and I think the difference between the right and left leg is remarkable. And then on the right, you see years of not using your muscles and the atrophy that can cause. So this gentleman's arms and legs have basically, the muscle has just wasted away. Immobility leads to contractures, which is the permanent shortening of muscles. And the healthcare team, our goal is to provide appropriate amount of rest and activity to prevent muscle atrophy and contractures. One of the most important aspects about our patients who are not mobile or have been on bed rest and we're not getting them up and moving around is that they are at an increased risk for venous stasis and clot formation, putting the patient at risk for a pulmonary embolism. So we've talked about this in several of the presentations, but it is extremely important in that when that clot forms in the lower extremities and the legs, what ends up happening is you can see a clot can break off, and then that travels up into the heart and the pulmonary system and can kill a patient. Here's pictures of people who actually have a clot in their leg, and you can see that the leg is swollen and it's red. Of course, if you would see this in your patient, this is, of course, abnormal, and you would report that to the nurse right away. Here's some pictures of pulmonary embolisms that have been removed. The top figure is one that was removed in an autopsy, and it actually takes on the shape of the vein that it was in, that the clot formed. And the lower picture is illustrates a person who underwent a thrombectomy. They removed that clot and then they laid it up onto the leg where it was. So you can see these things can be massive, and these are extreme examples, but you can imagine that if that would travel up into the heart and the lungs and block everything off, and then that's why our patients can die quickly when the clot breaks loose and travels up. We can prevent clots by using anti-embolism stockings as well as ambulation, getting them up and walking them around. Anti-embolism stockings, also you can sometimes hear them referred to as TED hose. These are stockings. They can either be knee-high or thigh-high, and they're very tight in their compression. And so what they do is that compression helps the blood flow in the legs and prevents clots. So a person it's important when a person has an order for TED hose to make sure that they are wearing them and wearing them constantly. Usually what happens is that they're measured for the right size. Usually 2 pair are ordered, so one you can wash out in the sink and dry while and clean them, and they'll still have another pair to use. This is also something you'll see a lot. These are the sequentials. They're called the sequential compression devices, and it has a pump at the end of the bed, and it is putting pressure on and then releasing pressure, putting pressure on and then releasing pressure. And that motion and movement helps, again, the blood flow up to the heart, so it prevents the blood from clotting, and prevents the formation of clots. So ideally, we want our patients up and ambulating, walking around, and we have several aids for assisting that patient to walk. We have a wonderful physical therapy department here, an occupational therapy department here. They'll come and fit canes and walkers and crutches to patients. But just so you know, on canes, when a person walks with a cane, it should be at the height of the patient's waist and the elbow flexed 30 degrees when holding the cane. And then with walkers, extends to the patient's hip joint. And again, that elbow should be flexed 30 degrees and only move 6 to 8 inches ahead. I don't know if you've seen people who will pick up their walker and like move them 12 inches ahead, and then they're trying to take a couple of steps to catch up with their walker. That's a fall hazard. And again, physical therapy works with those patients on how to properly use the walker, but then when we're up ambulating our patients, we want to reinforce that as well. Crutches, crutch gates about 6 inches in front of and to the side of the patient's foot. That's as far as you want to move the crutch ahead. And then the top of the crutch, you don't want that pressing up against the axilla where there's a nerve that can cause nerve damage. So it needs to be below that armpit. And then we have the gait belt. The gait belt is a device applied around the waist and used to help support a person who is unsteady on their feet. So you can hold it, you grab it from underneath, and you can do gentle corrections with it. They tend to be leaning towards one side. You can gently correct them to the other. And if they should start to fall, you can grasp the gait belt and have a nice control of that fall as well. Positioning patients. It's important to follow the basics of positioning a patient in a bed, which is lock the bed. Always lock the bed. Make sure those bed breaks are locked, and bring the bed up to a working height, which is usually at hip level. You always check around the beds for any tubes or wires might be connected to the patient. We do not want to pull anything out. And then if you're positioning them, pulling them up in bed, of course we want to lower the head of bed. You don't want to be pulling anybody uphill. Ask the patient if they will be able to assist. And if they can, we have them cross their arms on their chest. And then we have our feet shoulder width apart, which we know from good body mechanics. And we're going to bend our knees. And then it's a coordinated effort. On the count of 1, 2, 3, on 3, we're going to pull them up. We're going to instruct the patient to push off the bed with their feet if they can. And then always, after we've positioned them, always check the patient for alignment. Once you've gotten them all straightened out in bed, to make sure that they're nice and aligned, they're not leaning towards one way, we don't have a shoulder caught up under them. To make sure that they're nice and comfortable. So let's talk about some of the basic positions a patient can be placed in. Supine position is a patient who is lying flat on their back. In side lying, it's also known as the lateral position. Some of that word got chopped off there, but that's a side lying position. You can see the patient is on their side, and notice the pillows, how they've got them under the arm, in between the legs, again protecting against any kind of bony prominences and skin breakdown. We have the Fowler's and the semi-Fowler's position. So a Fowler's position, the patient's head of the bed is at a 45 degree, angle, and the hips may or may not be flexed. It's a common position to provide patient comfort and care. Many patients want the head of their bed up. If it's at a 30-degree angle, that's what we call a semi-Fowler's position. And often that is used for patients who have cardiac or respiratory conditions. Sometimes patients with nasogastric tube, we want the head of the bed up a little bit to prevent some aspiration. And then we have the Trendelenburg position. And this is when the head of the bed is lower than the feet. So this position is used in conditions, medical emergencies, and hypotension. If your patient has a really low blood pressure, we'll put the patient in Trendelenburg, increase that blood pressure. It helps promote the venous return to the major organs, such as the head and the heart. For positioning patients, we have some common devices that are used, such as just a standardized pillow. We can tuck behind a patient's back, keep them from rolling over. We can tuck them in between the patient's legs to keep those bony prominences from rubbing on each other and getting skin breakdown. There are specialized pillows called wedges, and these can tuck right behind the patient's back as well, keep them on their side. Here's one you can see, another type of pillow that elevate the feet and are actually floating those heels off the bed. Mattresses, we have the standard mattresses, and then they have a lot of different kinds of highly specialized air mattresses now to help prevent skin breakdown. And adjustable beds. All of our standard hospital beds are adjustable beds, and we do have rotating beds, and those are what you see in the ICU that can actually rotate a patient 360 degrees. Additionally, we have trapeze bars that kind of gets hooked up to the headboard here, and that's for orthopedic patients mainly. They can grab hold of that and help pull themselves up into bed. Foot boots, or we use here the Prevlon boot here. And as you can see, this kind of holds the foot into a nice position, as well as, you can't see it here, but the heel, it relieves pressure on the heel. There's a cutout there, and it cushions that heel to prevent heel breakdown. We don't float the heels on pillows. We use these Prevlon boots to help protect those heels. And then hand rolls, and you can see here just one simply made out of a washcloth. And all it does is put that hand, a person who it'll hold that hand. We wrap the hand around the washcloth in a somewhat functional position so it doesn't, and prevents that tight contraction. They also have the wedge pillows for, and this is again for hips, to keep those hips aligned for a person who has a fractured hip or has had hip surgery. We do have foot boards here, as well as the foot boot. And what that does is that keeps the foot in an upright position and keeps it from flopping down, for lack of a better term, which can happen when patients are on bed rest for extended amounts of time. After positioning your patient, always make sure that call light is in reach. You might have turned them to the side where now they cannot access their call light. Make sure that body alignment is good, or stand at the end of the bed, kind of look, make sure their body is straight. And also, all 4 side rails are not up. As we've talked about, or will talk about, if you have all 4 side rails up, it's considered a restraint, and it doesn't keep the patient in bed. What happens is they will either try to go under or through, or get kind of caught up in the side rails, as you can see in this picture. So when we get into the lab, we'll kind of show some of the positions that a patient can be in, and especially I can't stress the importance enough of the proper positioning of a patient, and especially protective positioning, so that the patient, we're turning them every 2 hours, getting them in a good position. We don't want them to develop any kind of pressure injury, and we can do that by properly positioning them and then using pillows to protect those bony areas. And that concludes the mobility and positioning of the patient.